All right, so here we go. So first of all, I have nothing to disclose other than I'm a practitioner in the Coat Clinic at WVU Medicine. So here's an outline of what I'm going to talk about today. So I'm going to start out with the science, talking about morphine equivalents and the potency of Suboxone. And then I'm going to talk about the ceiling effect, which has to do with Suboxone or buprenorphine being a partial agonist. And then I'm going to talk about mu-opiate receptor affinity, or how strongly the buprenorphine binds to the receptor. I'm going to talk about the percentage of opiate receptors that are occupied at different doses of Suboxone. And then I'm going to talk about kind of where we've come from with what we learned about dosing with methadone maintenance treatment, and then how that translates to the treatment with Suboxone. And then I'll talk about induction of Suboxone, maintenance treatment with Suboxone, tapering off Suboxone, and then some special populations, comorbid pain and opiate use disorder, and using Suboxone in that situation, and then strategic dosing during pregnancy. And then we'll end with some future research ideas. All right. So first of all, morphine equivalents. So the way that morphine equivalents are developed, it's really about analgesia or pain relief. And so if somebody sticks their hand into a bucket of ice cold water, how long can they keep their hand in the water and be able to bear the pain until they have to pull it out? And so different opiate medications make it easier to tolerate pain. And that's kind of the way they measure the morphine equivalents. And so buprenorphine is 30 to 100 times more potent than morphine. And so here's a table. This is from the Massachusetts General Hospital Manual of Hospital Psychiatry. And if you look at third from the bottom, where buprenorphine is 0.3 milligrams orally, is equal to the top there, morphine at 30 milligrams. So this is 100 times more potent, they're saying. And different literature kind of suggests different potencies. This is the highest potency that's suggested. And then if you look back at buprenorphine, if you look at the duration of action, analgesia is only about 4 to 6 hours in duration. So also there's a ceiling effect with buprenorphine, and this is because buprenorphine is a partial agonist to the mu-opiate receptor. And what a partial agonist means is that it doesn't work as strongly as a full agonist. And so even though it's quite potent, it has a ceiling effect where only so much potency can take place, only so much effect can take place. And so that limits respiratory depression, it makes it safer. It limits the euphoric effects of Suboxone, and also it limits the analgesic effects at higher doses. And so you only get so much bang for your buck with the analgesia. Even though it's quite potent, at low doses, there is a ceiling effect. Now, I know this slide is small, and I apologize for that. I tried to enlarge it, and it gets very blurry. So, but what this is about is the affinity for the mu-opiate receptor. And so different drugs bind to receptors with different power of binding. And so the K value is the affinity or binding power of a drug. And the lower the K value, the more affinity. And so if you look at fentanyl, that's the one that has the lowest K value or the highest affinity. So it has even more affinity for the receptor than buprenorphine, which has a pretty strong affinity. And so what happens is when you combine both buprenorphine and fentanyl, fentanyl is going to compete out the buprenorphine because of the affinity for the receptor. Whereas buprenorphine with other drugs like hydrocodone or oxycodone, the buprenorphine is going to compete out the other opiates. Now this slide is about a study looking at the mu-opiate receptor occupancy. And so what I'm talking about is at what dose, at various doses, what percentage of mu-opiate receptors are occupied by the buprenorphine. And so what they did is they did PET scans and they radio-labeled carfentanil. And they saturated the receptors with carfentanil that was radio-labeled. And then they added buprenorphine and the buprenorphine displaced the carfentanil. So at 2 milligrams, 36 to 50% of the receptors were displaced. And at 16 milligrams, 79 to 95% of the receptors are displaced. So that's, the thinking about Suboxone largely is that there's not much reason to go above 16 milligrams in the majority of patients. And here's the science behind that, because really what's happening is that most of the receptors are saturated at 16 milligrams. All right, so let's talk about methadone dosing. So if you go back to the 1970s, Dole and Neiswander in Rochester, New York, developed the idea of using methadone as a maintenance treatment for opiate use disorder. And so out of that has developed kind of the thinking behind how do we use these medications to prevent people from overdosing on opiates and help them stop using abusable opiate drugs. And so there was kind of three things that were achieved by methadone maintenance treatment. And one of the most important things was something called a blocking dose. And so what do I mean by a blocking dose? A blocking dose is a dose where if a patient uses heroin or another opiate, they're not going to feel anything because the receptors are saturated by the methadone. And so that's a blocking dose of methadone. And so the goal was to have patients, when a patient's on methadone, they may try heroin, but they kind of have extinction of the behavior. If you're not rewarded for behavior, you get kind of an extinction burst, which is more of the behavior. And then eventually it just stops. The behavior kind of tapers off and stops. And so that's kind of the science behind using methadone. And of course, we were also eliminating withdrawal and cravings. And so that's kind of the thinking behind how do we dose these medicines, both Suboxone and methadone, to treat people for opiate use disorder. All right, so let's talk about how do you get people onto Suboxone. Well, Suboxone has some unique properties to it. Because buprenorphine is a partial agonist, if somebody has a dependence or physiologic dependence on opiates, you can't just start them immediately on Suboxone while they have opiates in their system. And the reason for that is because Suboxone or buprenorphine is a partial agonist, it's going to precipitate withdrawal in the individual who's using a full agonist opiate. And so they have to be in withdrawal to start the Suboxone. And so I don't know if you're familiar with the withdrawal scale, the COWS, but usually a 13 or more is a pretty good place to say, well, this person's in enough withdrawal that they can tolerate starting Suboxone. And so patients have a pretty good idea. The majority of people who are using opiates have tried Suboxone on the street, and they kind of are savvy about what they need to do to use Suboxone on their own. But if you were going to kind of, when the beginning of Suboxone treatment became available, we were very careful about inductions, and the important thing was to not induce withdrawal or precipitate withdrawal in patients who are physiologically dependent. And so people who use Suboxone off the street, one of the things that you can ask them is, what's the least you can get by with? How can you deal with just the least Suboxone? Where are you comfortable at the lowest dose? And so that'll give you a sense of where to start. And so often, patients will start at more than the recommended, FDA recommended 8 milligrams on day 1, or 16 milligrams on day 2, or 24 milligrams on day 3, or 32 milligrams on day 4. It's very rare that a patient is going to be prescribed 24 or 32 milligrams or anything above 16 milligrams, really. And so 16 is kind of the usual maximum dose. And I think there's one patient in the 3 years that I've been here at WVU that I've prescribed more than 16 milligrams to. So it's a rare instance that you do that. Now, Patrick Marshallek, I was talking with him about what his thinking is about inducting patients on Suboxone and how he selects the dose. And he says that he thinks about it, that the use pattern like a small, medium, large, extra large. And so someone who's using a small amount, that's 4 milligrams, And then it is a small, medium, large, extra large would be like 4 milligrams, 8 milligrams, 12 milligrams, 16 milligrams. And so you want to kind of approximate based on how much this person is using, where they fall in that kind of quantifying the amount that they would need. And I think that, you know, there is kind of an art to that, to understanding how much someone's going to require. And it doesn't hurt to err on the side of caution. But one thing that is important is if someone is still in withdrawal and you're moving very slowly with the dose, increasing it or titrating it, you might lose them. They might drop out of treatment. And so aggressively treating withdrawal with Suboxone is super important to prevent the patient from dropping out of treatment. Now, of course, if you've precipitated withdrawal in somebody who is physiologically dependent and you didn't wait long enough for them to be in significant withdrawal and the withdrawal got worse after you started the Suboxone, you're going to have to wait it out a little bit until the withdrawal gets more pronounced before you start using the Suboxone. Now, longer acting opioids like methadone has a 24 to 36 hour half-life. So you're going to have to wait 24 to 36 hours before you start the Suboxone. Now, there is an exception to this. There's new literature that suggests that you can cross-taper methadone and Suboxone. And so what that means is that, and I know Dr. Husted has done this in the inpatient setting, but you can start somebody who's on a very high dose of methadone onto a very low dose of Suboxone. So you're not going to precipitate withdrawal because it's just a tiny little dose. And then as you gradually increase just a little increments, the Suboxone, you're not precipitating withdrawal, but slowly displacing the methadone with Suboxone. And maybe Dr. Husted wants to say something about that, but I think that's a kind of an interesting way of getting people from methadone to Suboxone.
Yeah, it's not as complicated as people think. I was a little scared to do it the first time. I've done it a couple times now. Really, all you do is, so you keep them on whatever methadone dose they're normally taking. So you don't change that at first. You start them on a tiny dose, like you said, typically 1 milligram. So, you know, half of a 2 film, but you actually don't have to incrementally really slowly increase it. So you essentially double the dose over about 5 or 6 days. So what we've done is 1 milligram, 2 milligrams, 4 milligrams, 8, and then either to 12 or 16. So you can, within 5 days, get somebody onto a full dose of Suboxone, and then literally all you do is you cut out the methadone. So by then, once you're on 16, the methadone's pretty much not binding anyways. It's just kind of floating around there. So it's not as complicated as I thought. I've done it a couple times now, and I don't know if I'm brave enough to do it as an outpatient yet, but inpatient, it's not too hard. And you can still take the like clonidines and ibuprofens and things like that. So it's not too complicated.
Now, I have inherited a patient who had that done in the outpatient program. And they were reporting some odd feelings and not quite feeling comfortable yet. But that dissipated over time, and now he's stable on his dose of Suboxone. Mm-hmm. So there may be some residual kind of discomforts, but nothing miserable that he couldn't get through. He just didn't quite feel, okay.
It's better than stopping someone fully on methadone, letting him get it going to severe withdrawals 2 or 3 days later, and then starting you because, or methadone and then starting you because you're probably going to lose them at that point.
Yeah, so the original thinking was that somebody would have to taper their methadone down to 30 milligrams before they could be transferred over to Suboxone. And the usual effective dose of methadone is around 60 to 80 milligrams. And some people are on much higher doses. I know in this part of the country, I think people are pretty aggressive with the dosing of methadone. And you see people on really high doses. But so the precipitating the withdrawal becomes even more of an issue at higher doses, and the withdrawal, just the phenomenon of withdrawal is going to be tougher at a higher dose. All right, so what about maintenance dosing? So, if somebody has ongoing craving or positive screens for opiates on their drug screen, you need to escalate the dose. And so usually in increments of 2 to 4 milligrams of buprenorphine. each, prescribed per day. And people get in trouble. You kind of think, well, this person was comfortable when I started out with inducting them into the Suboxone, and they were doing well on 8 milligrams, but now they're using, fentanyl and heroin, and so that's not okay. So you need to get them to a place where they're not craving to use opiates and they feel comfortable. And so you have to escalate the dose. So the dose you start at may not be the dose that you arrive at in a maintenance treatment. And also keep in mind that the half-life of buprenorphine is 24 to 42 hours. And the reason why it's so prolonged is because it dissociates slowly from the mu opiate receptor. And so it takes 4 to 5 half-lives to get to a steady state. So you're going to have peaks and troughs and peaks and troughs. And so it takes 4 to 5 half-lives to get to a steady state. And so we're talking about a week or maybe a little bit more before patients are really at a stable amount experience with the new dose of buprenorphine or Suboxone. And so, it's kind of nice. It fits well with the weekly kind of format that we have for seeing patients when they start out in outpatient treatment. So you make adjustments in their dose and they're at a steady state when they come back. So what they're reporting then is kind of a good information for you about how they're doing on that dose. And then patients with high tolerance for opiates, severe addiction, and comorbid psychiatric disorders may be requiring higher doses of medication to do well. And so you want to kind of keep those 3 populations in mind: high tolerance for opiates, severe addiction, and comorbid psychiatric disorders. And so the language, I think it's helpful to develop language around, what is the right dose for this person. And the language that's always worked for me is to say, how is this holding you? How's the Suboxone holding you? And something about the holding term kind of works well for them to say, yeah, I'm comfortable. This is a good dose for me, and I can function and live a good life and raise a family and work and be productive. And so, of course, at higher doses, they get that nodding and sedation, and if the dose is too low, they're craving and withdrawal, or so you want to find that kind of good dose where it's holding them well. All right, so what about tapering people off of Suboxone? So the recommendations, the most recent article I read was in the American Journal of Psychiatry, and this article said that the study was a very large N. I don't have the exact data on the study, but they said that 18 months is kind of the recommended point of sobriety at which you would think about tapering somebody off of Suboxone. And if you do it earlier, you're at risk of overdose or relapse. And so also the finding of that study was that people with comorbid psychiatric conditions are much more likely to relapse or overdose. And so really the thinking about them maybe is that they should be maintained indefinitely on maintenance opiate treatment, maintenance Suboxone or methadone. And also when you're tapering people off of Suboxone, you want to think about the percentage decrease. So, it's going to be the percentage drop in receptor occupancy that the patient is going to feel. And so if somebody's at a high dose, if you go by a certain amount, that's going to be a smaller percentage than at a lower dose. And so as you get to lower and lower doses, you got to slow down and taper more gradually in smaller increments. And so usually the recommendation to taper opiates is like 10 to 20% per week or slower. And for someone who's been on methadone for a year or more, or Suboxone for a year or more, you're really thinking about tapering them over months, to really prolong the taper so that they're comfortable and they're not going to precipitate withdrawal or urges to use and feel uncomfortable and relapse. If craving reemerges, then you got to slow the taper down. And of course, many patients do well with continual maintenance treatment for years. And I have some patients who are in my bi-monthly group who have 10 years of sobriety or more. And so they've been here for a long time getting treatment with Suboxone, and they do great. You know, they're working, raising families, productive, healthy, and they're happy, functioning well on maintenance Suboxone. And so the things that are affected by maintenance treatment that do well is employment outcomes and stronger relationships and less crime and better health. And so we need to get more science about that, but I think those are the things that really matter to people. Now let's talk about comorbid pain and opiate use disorder. So people who are on opiates or opiate maintenance treatment can have pain, of course. They may have surgery, they may have chronic pain, they may have an injury of some kind. So for breakthrough pain status post-surgery in somebody who's maintained on Suboxone, you're usually thinking about 1 to 2 milligrams of buprenorphine, every 4 to 6 hours. And so you remember the duration, 4 to 6 hours is the duration of analgesic effect of buprenorphine. And so you're adding on top of their maintenance dose 1 to 2 milligrams PRN for the usual course of opiate treatment after surgery. And then for patients who are on maintenance treatment but being treated for comorbid chronic pain conditions, the most important thing about treating pain in people who have opiate use disorder is that you don't over focus on pain itself. You know, that you want to kind of have expectation management, and the elimination of pain may not be realistic for a large percentage of patients with chronic pain. And of course you want to improve their distress and reduce pain, but the goal is functioning. So you want the patients to function well. And so you're really looking at, what's their daily life like? You know, how active are they? Are they able to interact with their children? Are they able to cook and clean and do things around the activities of daily living? And so you're really interested in their activity. And so it's very hard to treat pain in people who are on Suboxone for maintenance treatment by seeing them by video conferencing, because you're not going to be able to see how they're functioning. And so when I treat people at the Center for Integrative Pain Management in our high-risk pain clinic, who have both opiate use disorder and pain, and we're meeting with them in person even during the pandemic, because it's just difficult to assess pain in somebody you're not actually seeing their body and how they're moving. And so I hope you understand how difficult that can be. So also remember morphine equivalent. So the Suboxone, the buprenorphine is very potent, 100 times more potent than morphine. So in someone who's opiate naive, 1 milligram twice a day of buprenorphine is going to give them a great analgesic effect. And somebody who's been on Suboxone for maintenance treatment of opiate use disorder, you're going to be looking at using higher doses. Or if somebody's been maintained on transdermal fentanyl or other high dose opiates, then you're going to be looking at using a higher dose of Suboxone. But keep the ceiling effect in mind. So after a certain, I'm not sure where that dose is exactly, where the ceiling effect occurs, and I don't think that's been worked out entirely. But that you're going to start losing analgesic effect at some dose, and then you might even get hyperalgesia, or I'm blanking on the term, hyperalgesia, where the pain increases with a higher dose opiate. And then also, since the duration of action of analgesic effect is so short, BID or TID dosing, or twice a day or 3 times a day for analgesia is the recommendation for chronic pain. All right, so what about strategic dosing during pregnancy? So one thing that happens when someone is getting further along in their pregnancy is that the total body water changes in the woman. And so they may require an adjustment in dosage because of this increase in body water. And so a patient may start to report that they're not feeling comfortable. So the Suboxone is not holding them like it used to. And so it's perfectly reasonable to adjust the dosage upward during pregnancy. And another thing that you may have to do is use divided doses or increase the frequency of dose that the patient is getting during pregnancy to maintain plasma levels. So that's just kind of a unique thing that happens physiologically with somebody who's pregnant, is that they don't maintain plasma levels like somebody who doesn't have all that body water. All right, so what about future research? So Dr. Husted, again, he's going to be involved in a head-to-head study of sublingual versus long-acting formulations of Suboxone or buprenorphine. And I think that's kind of what we're thinking about. And there's just to think out loud about what the differences would be. So one of the advantages of sublingual formulations of Suboxone is that we see the patient more often. If a patient's getting a once-a-month injection of buprenorphine, you're not going to see them as often, possibly, and they may, you're not going to have a relationship develop with the patient that you would seeing them more often, and you may lose touch with that patient. And so it's a complex thing. It's not just the pharmacology here, but the interaction with the clinician that's going to be affected by the formulations that we're using to treat people. And then also dosing and long-term retention in treatment is an interesting question. So, at what doses do patients stay in treatment? And so, I've got these people who've been in treatment for 10 years, and there's a wide variety in doses. There's patients who are on 2 milligrams, and then there's patients who are on 16 milligrams. So there's a wide variety of doses. And so maybe that's the answer, that the dose needs to be tailored to the individual in a very unique and thoughtful way. Or maybe there's actually going to be some data that shows that over a long period of time, people who are on a given dose that occupies a certain percentage of receptors is going to be optimal for retention and treatment. And then along those lines, how is dosing going to affect work and relationships and crime and health outcomes? We don't tend to think about crime as an outcome measure in our program and treating people with opiate use disorder. But actually, the reason that drugs of abuse became illegal was really because of the crime associated with them. And so it is an important outcome. That's what affects kind of the public, is the crime associated with it. And so that's something to be looking at, is how much crime is being reduced by a different dose of Suboxone. All right, any questions?
Thank you so much, Dr. Herschler. That was awesome. We'll open it up for the group. Any questions or comments?
Yeah. Okay, so what do you all think about this? So I read the part when during pregnancy, the ladies need more because of the increase in blood volume. However, I had a lady who just delivered, and she actually needed to double her dose. She was on 8, and she had to go up to 16 afterwards. And I wasn't too sure whether her pregnancy, being pregnant, because it was 16 years between her and her last son, kind of protected her from using. But I was really surprised that she had legit cravings, and she said to go through withdrawal, and she did need to go up on her Suboxone dose, well, buprenorphine dose. Have you all seen that before?
Yeah, so I definitely have seen, I have been working with Suboxone for a while now. I actually was involved in the trials looking at buprenorphine back in the 2000s, early 2000s, when we were studying it, as a maintenance treatment. And definitely women who are pregnant, will often require a higher dose. And there are exceptions to that, where patients just say they're doing okay. But so if someone's telling you they're not comfortable, I would be very liberal with adjusting the dose to make them comfortable. And you don't want them to be out there, using or being triggered by their cravings and get back in kind of out to the races and using substances again. So it's an important time to keep them stable.
I've also, Dina, seen it a couple of times after delivery where for whatever reason, they did have a lot of cravings, and they were pretty stable during their pregnancy on the same dose, but after the pregnancy, for whatever reasons, they did notice that it was a harder time for them, and I've increased the dose during that time too.
I think COVID COVID plus just had a baby would probably make me crave more to use too. So, you know, I feel like in general, the cravings have been higher with COVID and dosing a little bit more liberally, actually. So I wouldn't be surprised if that was playing a role too.
You're looking pretty good, Dr. Husted, for just having a baby too.
Yeah, I know. Yeah, 5 months, almost 6 months. Thank you.
Any other questions or comments? Anyone from the group experience dosing Suboxone and maintaining it? I know we didn't have a case today, so feel free to unmute and share some experiences. Laura, was there something you wanted to comment on?
Yeah, I did have a question about the opioid dependence and chronic pain management. I'm trying to figure out how to word it. So there's a person on our team that at a former clinic, the approach of pain management was very frowned upon, like it would be a big no-no. So that's actually a question I have had for a couple of weeks, is clarification on, you know, I know that we're not a pain clinic, but also if a person has chronic pain, they're going to go out on the street and buy opioids to treat that pain. So it's kind of like that harm reduction factor there. Just basically, I just need clarification on, you know, is it okay to have that conversation of pain management along with the opioid dependence? And is it acceptable, like, to document that as well?
Okay, so I know for our practice, as long as they meet the criteria for opioid use disorder, yes, I treat both, and we just do as Jeremy said, just split it in divided doses and add your adjunctive. But we have had a lot of patients actually refer to us because their urologists retired and they were in super high doses of opioids, and now no doctor wants to see them, and they're coming to us for pain. But these patients don't necessarily meet the criteria for opioid use disorder, right? They don't have the aberrant behavior, they don't have the compulsive use. What they have is tolerance and withdrawal. Those are not candidates for Suboxone. At least I didn't think so. But I only feed both if they meet the criteria, clear-cut criteria, and I do document, because when you give it divided doses, you have to say in your notes that's why you're dividing the doses. Otherwise, it can be a flag.
Right.
I think where you get in trouble is where you're doing it specifically for pain by itself, but if you're treating both, they can't really knock you for that too. That's the other thing to keep in mind. And you are going to treat both, you know, whether you want to or not. It's going to happen. So I don't think it's trouble, again, as long as you meet the criteria for it. I mean, it's safe long term, you know. So, but I'll leave it to Herschler. I know.
Yeah, so there is Butrans, which is a form of buprenorphine that is a transdermal, that is not Suboxone, that can be used for pain in someone who doesn't have any aberrant behavior related to opiates. But I think I'm a little bit more flexible about the criteria for opiate use disorder in people who have chronic pain. So somebody who's running out of medication early, or taking more than prescribed, or having positive drug screens for other things. You know, those are all people that I'm thinking about, you know, maybe they have an opiate use disorder and really belong in a program where you're treating both opiate use disorder and chronic pain. Does that make sense?
Yeah.
Also, just to be clear and somewhat provocative, is you can prescribe Suboxone for pain if you have a controlled substance license to prescribe. It's only, you would need the X waiver technically in order to use it to treat addiction. So that is a possibility. I'd be curious to hear Mark's take on that when he gets a prescription into the pharmacy from somebody who's not X waivered and with a doc trying to fill it for pain.
I'll take it a step further, Jim. If Mike from the Board of Pharmacy, who runs it, called me on that, I would confirm for him that is, as per the law, perfectly legal. The process, I would expect a phone call or 7. That's for you guys prescribing. You know, can you just write pain on the script? if I'm the dispenser, I'm probably still calling you. Just to double check and make sure. But in the end, it's probably going to be a great I hope it's going to be a great conversation. When it is for the use of pain, buprenorphine products, that's fine. Now, the stipulation in that particular regard with Suboxone, buprenorphine, naloxone, oh my gosh, maybe we're going off label. I don't know if you've ever heard of this off-label utilization of medicines, but it's spectacular. It's amazing. It happens it just happened like 75,000 times in the last minute. That might not be what you get on the other side of the horn. But keeping that in mind of the levity there of off-label use, it's the medicines are the medicines. Sorry, that was probably long-winded, but really wanted to drive that one home.
One of the biggest obstacles to using Suboxone just for pain in someone who doesn't have opiate use disorder is the insurance company may not cover it. And so they would be paying out of pocket for the Suboxone.
Sorry, I was facetious there. The 7 phone calls, 6 of those were insurance. 1 was the actual pharmacy. I skipped over a little bit there, yes.
Yeah, so the take-home point is, in many ways, I would much rather see somebody on buprenorphine for pain than any other full opioid for pain, just because of the safety profile compared to the full opioids. However, if you're going to do that, just realize that you're going to get a lot of calls from insurance companies and from the pharmacists. It's not going to be a smooth and easy process, but it's certainly it's a legal thing to do. And if you're doing it well and with the appropriate safeguards, I would consider it to be within the standard of care.
Sarah, I noticed you had unmuted and chatted in. Was there something?
Yeah, I was thinking that the data waiver allowed nurse practitioners to treat with Suboxone only for opiate use disorder, not for the pain. So that was just kind of what I was looking at.
Yeah, so remember, the whole reason why we had to go through the data waiver training to get a special exception from the DEA is because of a rule that goes way back that says you cannot prescribe a controlled substance to treat addiction. It doesn't say you can't prescribe a controlled substance to treat pain or any other condition, okay? So that's the caveat and the nuance that I'm highlighting.
And to emphasize that, to my knowledge in all the legal books, specifically mid-level practitioners are allowed in our state of West Virginia to prescribe C3s, C4s, and C5s, and buprenorphine is a C3. The data waiver, as you guys were just talking about, is specific to the utilization as MAT.
Oh, that's wonderful, because I was so scared to even write it like twice a day. Because I was like, it might be considered for being used for pain. I feel so silly now. That's good to know. Thanks, guys.
That's awesome. Don't feel silly. This is a safe space, and that's what it's not for. That's awesome, though. Any other comments or questions?
I've been scared to document anything about pain. Like, I mean, I've done the research and had unofficial conversations on different ways to take the medication, but yeah, so it makes me feel better too to know that it's not taboo.
And you go into any one of my notes, if you were to do a deep dive of my notes, and you'll find a few notes that I did last week even where I said, because of this person's pain, I've increased the dose to such.
When it comes to this sensationalized stigma, and I'll find another S word here for us with this, the provocative side of it all, what I usually just say is, what if this product or these products came out in 1996? Technically approved in December 1995, if you smell what I'm cooking here. Boy, what a different world.
Anyone else have some comments or experiences you'd like to share with the group? still have about 15 minutes.
I have a question. I'm wondering what other people have done. I haven't seen this since I've been working in addiction treatment, but when I was working in primary care, I saw 2 cases where the patient's drug of choice and first opioid exposure was buprenorphine. And so their addiction was Suboxone. How do you guys look at that, or do you look at it any differently as far as dosing or plan of care or expectations?
So my take on that is that Suboxone is unique because it does affect the mu opiate receptor and the pleasure of opiates in the way that other opiates do, but it has some other effects. It blocks the kappa opiate receptor and kind of blocks the suffering pathway. So you can see why someone might selectively like Suboxone as opposed to hydrocodone or heroin or other opiates. But I think the treatment is going to be the same. So people are likely to use opiates erratically and overdose and switch from Suboxone to other opiates if they're buying it off the street. So I think the recommendation is to maintain them on Suboxone or methadone or Vivitrol and treat their opiate use disorder as we would anybody else.
I would agree with that. I would probably treat them the same way unless the patient said, listen, they were really honest with me, or over time we know they were injecting buprenorphine, even the dual product, the combination product. So either we found that they just couldn't stop injecting, or they themselves admitted they have such a problem just having the medicine. That would be somebody I would say would be a good candidate for Sublocade or the injectable forms. So you just take that out of their hands and try to work with the patient in that area. The other thing I would say that doesn't get exactly to your question, that's why I want to answer that first, is it does speak to the reality that we in the treatment field and advocates of MAT need to be very frank about the potential for these medicines to be abused, and that there is a market for them, and there's a reason there's a market for them. Now, we know that most of the people who are using the medicine are using it because they can't get access to us. And that's why we're doing everything we can to expand our footprint through Hub and Spoke and through Echo, et cetera. And so that would take care of most of the diversion if people were able to actually get in the treatment. But unlike some of my public health colleagues who will essentially say, why don't we just flood the communities with buprenorphine, put it in the vending machines that people could go ahead and just get buprenorphine whenever they wanted it. I think that's naive. I know where they're coming from, and I know that in communities where you do have more availability, that you do have a decrease in a lot of the harms. But at the same time, we got to be cognizant of the people who that could be their first drug of choice, or that could be their first exposure to a substance of addiction. And it's not uncommon where I have seen people come into my program over the last couple of years that buprenorphine is the first drug they've ever taken, and now they're addicted. Also, people still inject, and there's harms associated with injecting as well. And less important, but still important, is the problem that causes in the community when they see people misusing drugs, medications that we're prescribing. It lowers our credibility in the community. So I think we should be sober-minded about the problem, admit some of the challenges, but do so in a way that's going to be productive.
Thank you, Dr. Berry. Any other comments or questions or thoughts you'd like to share with everyone? All right, well, I don't want to hold you guys longer than I have to. I can give you guys 10 minutes back every Monday.
Dr. Beltira just got on, though. Yeah, I'm sure he has something to say.
Not sure about what, so. You know.
Anything. We would just love to hear whatever you have to say, since we're about to log off.
Okay. Thanks for putting me on the spot there, Dr. Barry. You know. So.
No worries at all, but we're happy you could join us. Anything you'd like to share with the group? Any updates or anything is fine.
No, we're doing okay. You know. So yep.
That's awesome. That's always great to hear. Thank you. And we will have this recorded and on our YouTube, so you're more than welcome to look at that as well.
Speaking of YouTube, all of you may want to go out and check on YouTube Jeremy Herschler, and he has a YouTube channel of his piano compositions and playing that are pretty remarkable. So for those of you who would like to spend some time enjoying some good music, check out Jeremy Herschler on YouTube.
Thank you, Jim. I welcome your feedback. It's just a hobby.
I think his latest song was inspired by me, and so that's why I'm saying that.
Well, that's incredible. We can put in the recap email. How about that?
There you go.
That's awesome, Dr. Herschler. And Dr. Bell also said that's awesome. We'll definitely check it out. So, well, thank you, Dr. Herschler, for the awesome didactic, and thank you all so much. I'll just go right into the announcements for next time. So our next session will be on December 14th, which I can't believe I'm saying this will be our last session of 2020. We do encourage you guys to continue submitting cases. I always put the direct link to the case form online and the recap emails and the reminder emails. And on that session, Dr. Barry will be discussing substance use disorder and COVID. So keep an eye out for that reminder email. And last but not least, I wish you all a safe and happy Thanksgiving. And you guys are all super inspirational. I'm grateful for all of you guys. So thank you very much, and we'll see you guys next time.
Yep, grateful for you all as well. Happy Thanksgiving.
Thank you, Dr. Barry. Thanks, guys.